Good day. I'm still Anna Nolte. We're still busy with the Mother Baby Friendly Initiative breastfeeding series, and we're busy with session 2. And this lesson 3, will be on the frequency of feedings. Now, when we talk about the frequency of feedings, it's kind of standing with both legs over what we've already said about the anatomy and the physiology, and it's also linked to a lot to what we will say in our next session when we talk about latching and attachment and cues that the mother should react on whether her baby is having enough milk or not. So you will hear a lot of repetition on what we've already said regarding the anatomy and physiology of the breasts, and how it's been related to how often and for how long the mother should feed the baby. But I, anyway, don't think you can hear enough of the anatomy and the physiology as it is. So I hope you enjoy. Now, this slide is to a very large extent lots of revision. We're talking about lactogenesis. That's basically the process of the milk being formed, the milk being coming in, the baby being drinking the milk, the whole process. Now, just some important aspects, and as I've said, we have talked about most of these already. So that is just a repetition, a revision. So we have already said that there are two processes, the milk synthesis and the milk release, and that both of these are very important. And we have said that if the milk is not removed, the increased pressure in the alveoli and in the ducts also causes a less capillary blood flow and inhibits the whole lactation process. So the breast eventually stops from producing milk. Now, a lack of sucking stimulation means also a lack of prolactin release. So the prolactin levels are totally depending on the suckling of the baby. And this is very important, specifically in the first postpartum weeks. Prolactin levels to a decrease to a very large extent after 4 months of breastfeeding, or 4 months after the birth of the baby. And also, again, it's like we've said previously, with the rooting reflex of the baby, it seems as if the breast then already has learned to produce milk. So prolactin eventually goes away. Now, prolactin makes milk, so there's a lot of milk in the breast, but if there's not oxytocin, the milk can't come out. So with it, the lay down reflex is very important for the baby to at least get the milk. More revision, more what we've said already. We've said that early and frequent suckling are our most important stimulators for prolactin receptors, and we need prolactin receptors in the alveoli to react to prolactin and to make breast milk. So this is very important. And then the more the baby suck, if there's an increased demand with more frequent and longer breastfeeding sessions, the more milk will be available. And this is, I think, one of the most important sentences in breastfeeding and in lactogenesis as there is. So the breasts literally makes milk according to demand. The more demand there is, with more, and the demand is being, I almost want to say, demonstrated by more frequent and longer breastfeedings, the more prolactin will be secreted and the more milk will be formed. We have said that the reduction in this demands will cause a reduction in prolactin and obviously a decrease in milk synthesis as well. Now, again, just a repetition again of what we said, that the breasts make milk according to demand. And that is so absolutely important. Now, variations in milk secretions are rapidly reflected in the anatomic changes in the mammary gland. If The milk shows regression in the first week or so after it's unstimulated, and we've said that the tissue, that the milk's not producing any, the breast is not producing any more milk, and the alveoli will go back to their pre-pregnancy condition, and that's why the milk, the breasts in general, are getting smaller, and I'm saying mammary tissue shows regression, meaning that basically the alveoli are getting smaller. Thus, when a suckling infant signals needs, the breast will respond. Then when we look at the part that the let-down reflex plays in lactogenesis, we have already said that if there's no let-down reflex, there's no movement of milk. Now, we have said that oxytocin has been released when the baby starts sucking, but there are also, and we have said that the oxytocin can be released by many other things, like, for example, seeing or touching or hearing or smelling or thinking about the infant also causes oxytocin to be released, while prolactin can only be released by nipple stimulation. So the production of milk can only be released by the baby being drinking, while the lay-down reflex can happen while the baby is not drinking. Now, the big problem with the let-down reflex is that it can be blocked or influenced by emotional disturbances, which is very important, because when the mother has been, and we will come to that a little bit in more detail as well, when the mother is stressed, or when she's anxious or not feeling confident, it might have a definite influence on the let-down reflex, which we see is very important for milk to move down. On the other hand, we've also said it's a positive kind of cycle, because when oxytocin is being secreted, it causes mothers to feel more relaxed as well. We have already talked about foremilk and hindmilk when we did the anatomy and the physiology. It's just very important to revise this again when we're talking about how frequent the baby should feed and for how long a baby should feed on a breast. We have said that the foremilk is the milk that's been in the breast, that's been stored in the breast between breastfeedings, and when the baby starts suckling, that's the milk that you will get out first. And the very important thing is that we have said that this foremilk is lower in fat than the hind milk. So it's very important that the baby should suck long enough on the breasts for both to get, in order to get both foremilk and hind milk, because hind milk starts to be formed as soon as the prolactin has been secreted, and these alveoli reacts to the prolactin and starts producing milk. And it has more fat, and we've said that the baby needs this more fat globules, because that provides the more calories that he needs to gain weight, and it also keeps him happy for much longer between his food, because that makes the stomach emptying time slower when there's a higher fat content, and we will get to that just now as well. Now, how often should mothers feed their babies then? How often should a baby be breastfed? And this again depends on, there's a lot of individual differences. It depends on from mothers to mothers, breasts to breasts, babies to babies. But this is more or less, again, when we talk about the perfect baby. Now, the original, and I think for most of you are a little bit older, have learned in the beginning that breastfeeding, mothers should breastfeed their babies about every 3 to 4 hours. And this was basically based on also, again, research that has been done with bottle feeding babies, because the emptying time of the stomach is much slower in the case of many of the formulas, and it takes up to 4 hours. So it takes up to 4 hours for a baby to become hungry again if it's been bottle fed. While the emptying time of the stomach for breast milk is much shorter. So that makes that more frequent feedings are absolutely essential. And I think that's, again, a wonderful way in which our bodies are being made, because we have said that the more frequent the baby feeds, the more prolactin is being secreted and the more milk is being secreted. So that's exactly what it says here. The more often the baby suckles at breast, the more it stimulates the production of prolactin and oxytocin. Now, what is then very important is how often should we then feed the babies? Now, during the first few days, and I think we all know that, and again, there's many individual differences. Babies are not very keen on feeding, and it's very difficult to really demand feeding them at first. One almost need to wake them up from time to time and to push them for the first few days before it's really been established. So, but again, as I'm saying, that differs between baby to baby. One, we all know that we get from the very first day of their birth, and they can never get enough, while the other babies are these ones that we need to wake up. Um, the ideal is that the baby should at least get 8 to 12 feeds during the 24 hours. So it means that the mother should always need to feed the baby from every 2 to 3 hours. Now, again, what's very important here, I'm talking about the first few days. I'm talking about almost the first few weeks. And again, it depends from mother to mother and from baby to baby. Babies usually establish a routine for themselves very quickly, and this more often stimulation of the breasts to make milk is usually only in the beginning, and usually when the baby has growth spurs, when we are and which we will come to again just now. So this very individual, but usually in the beginning, the baby needs to be fed more or less every 2 to 3 hours. And as we've said previously, most prolactin has been secreted at night. So night feedings are still very important. We have to wake the baby up at night. And again, it's only the first few weeks of breastfeeding that we need to do that. And then, as I've said now several times, babies differ. We get very hungry babies, we get not so hungry babies. It's like us. Some of us like to eat, and some of us don't really like to eat so often and so much. Now, if we talk just a little bit more about the so-called scheduled versus demand feeding. Now, demand feeding was the term that the concept that has always been used in the past, the so-called scheduled versus demand feeding. Now, there are many other words, terms that have replaced the demand feeding. It's cue feeding. It becomes cue feeding that the mother should feed the baby on the cues that he gives her, or it should be responsive feeding that the mother is giving feeding the baby according to his responses, which is basically more the same as cues. And there are some few other words that you will come across as well, which is being used in the place of so-called demand feeding. Now, new mothers might be very insecure and concerned about the lack of scheduling, and it's again depending to a very large extent on individual mothers. Some mothers want to feel more confident if they can plan and have a routine that they can say, I feed my baby every 3 hours from 9 o'clock or 12 o'clock and 3 o'clock. So between 9 and 12, I can do this and that and the other thing. And between 12 and 3, I can do this and that and the other thing. And unfortunately, we all know that that's not always working that way. But mothers really need to be educated about that because, as I've said, it can make them feel very insecure if there's no scheduling. And other mothers might thrive on random scheduling, feeding on the cues of the babies, and they don't need to worry about a schedule and a routine and etc. But the very important thing is we've said now so many times that the breast makes milk according to the demand. The baby needs to suck frequently and specifically in the beginning of breastfeeding to make more milk. So rigid feeding schedules, and specifically when it becomes further apart from each other, like in 4-hourly, might undermine the appropriate establishment of lactation, might make that the breast struggle to produce the milk that the baby needs. Now, again, Cochrane reviews has shown that the current standard of care, meaning the best practice, is to give feedings on um, uh, 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 on cue, to give feedings on cue, and there's no sufficient evidence to recommend scheduled feedings instead. Now, again, how often does she need to breastfeed then? The mothers might initially, and specifically in the beginning when they don't have a lot of confidence, and specifically also, again, first-time mothers, but also mothers who are breastfeeding for the third or fourth time, is they might feel as if they're nursing constantly, as if the baby is constantly drinking. And specifically for the mothers who had normal deliveries, who had long deliveries, who's tired, etc. It might they're tired and now the only thing that they do is to breastfeed the baby. But what they need to understand is that the milk, as they feed the baby more often, the milk supply will increase, and then the breaks between the feedings will get longer. So in most cases, mothers will be able to establish a more or less routine, and babies will feed kind of more 3-hourly and later on even 4-hourly. And this differs a little bit again when there are growth spurs, and again this is very individual. Some babies have growth spurs more often, some babies don't have growth spurs, but when the baby suddenly grow faster, again obviously his needs for milk will change. He needs more milk. So during these growth spur periods, the baby will the mother need to feed him more often again till the breasts have established the amount of milk that he wants. And good advice for these mothers is, and this also depends to a very large extent on individual circumstances, whether the mother can do it, whether she has enough support to be able to do it, but we can recommend the mother to take a 24-hour breastfeeding holiday. She can do it in the beginning when the baby is now a few days old and she tries to establish the breastfeeding, specifically when she has gone home, or also during these growth spurs, to take a 24-hour breastfeeding holiday where she just snuggle in bed, skin to skin with her baby, and do nothing else but feeding the baby when he's awake and when he's interested. So she relaxes. She's relaxed, which is, as we've said, is very important for oxytocin release. The baby drinks often and more frequent, and stimulates the breast to make more milk, and none of these two of them are being stressed. This hormonal stimulation by this 24-hour holiday is guaranteed to increase the milk. Now, how will the mother then know when the baby is hungry if she doesn't use a schedule? And this I'm not going to talk about at all now. We will do this in the next session on helping the mother to identify cues on when the baby is hungry and when he got enough milk, or when he didn't get enough milk, is all to be discussed next time. So in summary again, a healthy term unmedicated baby, that's what I meant by the so-called perfect baby, knows how often and for how long they need to feed. And that is what we call the so-called responsive feeding. Now, it's also, as I've said, there are many terms. The other terms are reciprocal, baby-led, and demand feeding, which are synonyms for responsive feeding. So, in other words, the baby knows how often and how long to feed, and that's the cues that we need to teach the mother. Now, mothers on medicated labors and birth need to know that their babies are going to be sleepy. So they should not leave their babies to sleep for prolonged periods, and specifically again, this few first days of after birth, where the breasts need to establish the breastfeeding. So they should definitely not leave the baby to sleep for longer than 6 hours. I already think that 6 hours is a very long time for a baby to sleep during the first 3 days, because then our incidence or possibility of hypoglycemia is also getting much bigger. So one shouldn't wait for the baby to give us cues to act on. But if it does give cues, one should immediately react on that. Now, when we look at the volume of food, how much food does the baby get during this first few days after the birth of the baby? Now, babies are usually born with a good glycogen reserve. Now, when the baby is being born, there are a lot of um, demands on his glycogen reserves, because in his first cry he uses a lot of energy and uses his glycogen. If he's cold, he use glucose to heat him up. If he's having a respiratory distress, he uses glucose to enable him to breathe. So there's a lot of demand on these glycogen reserves, but normally a well-grown term infant, in other words, my so-called perfect infant, has enough glycogen reserves. A stomach volume, and he has only a stomach volume of 5 to 7 mils for this first day and 22 to 30 mils for the third day. So what I'm saying here is that a baby, because he has a lot of glycogen reserves, he needs very little milk, and his stomach is very small. So they don't need large volumes of colostrum. So the baby needs to feed more often, not to get a lot of colostrum, but in order to stimulate the breasts to make more colostrum. Now, we say here that in the first 24 hours, the baby takes an average of 2 milliliters per kilogram per feed. And by the second 24 hours, this has increased to 4 milliliters per kilogram per feed. So a baby needs very little colostrum during the first few days. Now, if we also look at the patterns of intake, how babies drink, we will see that when babies there's a big difference between breastfed and bottle-fed infants and how they drink. In bottle-feeding infants, they suck steadily in a linear pattern. In other words, they just drink. And they receive about 81% of their feed in 10 minutes. In breastfeeding infants, they have a biphasic pattern. That means they drink a lot, then they stop a little bit, and then they drink a lot, and then they stop a little bit. So if we put, for example, this is not the idea, but if we, for example, put the baby for 4 minutes on the first breast and 4 minutes on the second breast, the baby receives about 84% of the total volume in those 8 minutes. So it means that the baby sucks differently in whether they suck whether they suck a bottle or whether they suck a breast. So what we are actually saying here, the most important thing is that the baby needs to be given time. A total in the beginning, a total feed duration of 14 minutes in the beginning, and then after a month he will feed more or less 10 minutes, and at 4 months of age he might even feed faster. So we don't need a long time for breastfeeding, but we need, in the beginning it will be slow, and then gradually it will become shorter. Now, when we come to how long should the breastfeeding session be? Now, I think all of you also a little bit older have learned that mothers should give 5 minutes on the one breast and then 5 minutes on the other breast, or 10 minutes on the one breast and then switch to the other breast, because both breasts have to be given at a breastfeeding session. But that has changed to a very large extent. We say now that sessions typically can last 20 to 30 minutes, but that's also very individual. That depends on the baby. Some babies drink fast, some babies drink slower. The lay down reflex in some cases are faster than in other cases. So it totally depends on individual babies and individual, I almost want to say, breasts. And then also initially in the beginning of breastfeeding, the first few days, it's taking longer, and then it gradually becomes shorter. The baby gets the amount of milk that he needs in a much shorter period. Again, because there are different factors that play a role. For example, the baby's sucking, the lay down reflex, etc. And then during growth spurts, the baby might suck longer on the breasts again to stimulate the breasts to form more milk. Now, there's a lot of debate also on draining one breast or draining both breasts or switching breasts, that both breasts are being fed on in one specific session. Now, the ideal is rather to drain one breast fully, and that's because of the whole issue about hind milk and fore milk. As we've said, fore milk is much lower in fats and therefore also in calories than hind milk. And it's very important that the baby gets both hind milk and fore milk. And the important thing is that we don't know. There's nothing that is an indicator for us that the baby is now switching or the breast is now switching from hind milk to fore milk. What we know is that some breasts take a little bit longer than other breasts to produce it, so it's much easier for the baby to drain one breast and make sure that he has received both hind milk and fore milk. And then you should start with the other breast at the next feeding, and that's the way in which we make sure that both breasts are being drained and that we don't get the inhibition of breast milk that we have talked about earlier. As I'm saying here, the major concern of switching is not that the feeding is long enough, but the fact that that the baby should get both hind milk and fore milk so that he can get the full calories of hind milk. And these calories, as we've said, are responsible for him to gain weight, and these calories are also responsible for him to stay satisfied for longer. So even if the baby gets enough volume, if he gets between the two breasts, he might get enough volume, but he does not get enough calories to meet his needs. So this is very, very important. The duration of the feeding should therefore also be determined by the infant's responses and not by how long it's been put on a breast. And we will, as I've said, we'll come to that next. How does the mother know that the baby is done? This is also some of the things that we will learn or talk about a lot in the next session. The baby normally let go of the nipple, the baby let go of the breast, or the baby swallow pattern slows down, and then also you know that the baby is getting more satisfied. These are the things that, as I've said, we will talk about lots next time. Or the baby fall asleep at the end of the first session, and then when he's been woken up and he's been winded a little bit, he will start drinking again on the second breast. But if he doesn't drink or is not interested in the second breast, then he can sleep through to the next feeding, and then it just needs to be fed on the next breast. If the baby doesn't let the breast go by himself, it should be unlatched again by putting in your finger into the corner of the infant's mouth. But this is also, again, something that we will talk about when we talk about the different cues. Then when we come to what might lead to a decrease in milk productions, these are all things that we will come into much more detail about: supplements, bottles, teat preference, pacifiers, scheduled feedings instead of demand feedings or cue feedings or responsive feeding, and babies' health problems, for example, premature babies or maternal health problems, and we will come to each one of these in much more detail. And that brings us to the end of lesson 3. I hope that you've learned something. I hope you've heard a lot of repetition. I'm sure you won't forget that again, so I'm sure you will get full marks in this quiz. Enjoy.